So my name is Alicia Heapy. I am a clinical health psychologist by training. I am an associate professor at Yale in the School of Medicine, Department of Psychiatry. And I am a health services researcher. I work at the VA. I'm the associate director of our Pain Research Informatics Multimorbidities and Education, or PRIME Center at VA Connecticut. So my background, most of my work is really around psychological and behavioral interventions for chronic pain, and testing interventions, especially ones that are delivered by technology. And that's kind of interesting considering the technology problems we've had here today. So I'm going to tell you a little bit about my work with a particular trial called IMPACT. So before we get started, I just want to make a couple disclosures. So I do get research support from the Department of Veterans Affairs and the National Institute of Health. And even though I am an employee of the VA, I have to say that this presentation does not reflect the official policy or positions of the Department of Veterans Affairs. So today, I just want to give you kind of like a brief background of some of my work on chronic pain. I am not an addictions researcher, and this is a newer aspect of my work. So just give you just a highlight or two on some of the things that are pertinent to the trial that I wanted to discuss. And then I want to talk about the IMPACT trial, which is really two parts: the development of an integrated treatment for chronic pain and opioid use disorder, and describe the trial that we're working on right now. Okay, so we're going to start with some of my work. It's generally called Comprehensive Pain Education and Self-Management, or COPES. Centers around a treatment that I've developed in my prior research, the technology-based self-management treatment for people who have chronic pain. So in terms of background, just to set the stage here around chronic pain, really starting about 10 to 12 years ago with a report by what used to be called the Institute of Medicine, and now it's the National Academy. They really identified pain as a public health challenge. They published a report that concluded that given the prevalence and the negative effects and the costs associated with pain, that it should be considered a public health challenge. And they called for a cultural transformation in the way that we look at pain and the way it's treated. The challenge of chronic pain was further reinforced by the recognition that opioid medications that had typically been used to treat pain were associated with serious harms, including opioid misuse, use disorders, and death. So since that time, treatment guidelines for chronic pain have changed quite markedly. The current recommendations say that opioid therapy should not be considered a first-line treatment, and multimodal approaches to pain care, especially ones that include non-drug approaches, are preferred. So things like physical therapy, exercise, and psychological approaches. Among the evidence-based psychological treatments, cognitive behavioral therapy, or CBT, for chronic pain is kind of one of the oldest and most well-studied psychological interventions. And it's quite effective for treating chronic pain. One of the problems is that there are overall a limited number of people who are trained to deliver this treatment. It requires a lot of in-person visits, typically anywhere from 8 to 12 kind of weekly 1-hour sessions. And that's really limited its wider use. So this is kind of when I came into my research career. So this is, I don't know, 2010 probably, where I really got involved, as many others did at that time and more have since, of thinking about, well, could we use technology to try to deliver CBT? And really some of the benefits of that are the provider could be located anywhere. They don't have to be geographically close to the patient. Patients don't have to travel. They don't have the burden of travel or scheduling barriers. It reduces the stigma that some people still feel about going for psychological treatment. And we know that it's effective. And so my first trial was called COPES. It was really testing this technology-based form of CBT for chronic pain. And in that trial, I compared it to going in the typical kind of CBT where you would go in and see a therapist once a week for treatment. And this is a study that was funded by the VA, and it was a non-inferiority trial with a hypothesis that veterans with chronic back pain who received this technology-based intervention, which was delivered by interactive voice response, or IVR. You may be familiar with IVR. It's a telephone-based technology where you can hear pre-recorded materials through your phone and answer pre-recorded questions or prompts using your telephone keypad. So we thought we would use this IVR-based system to deliver a CBT, and we wanted to see if it would demonstrate outcomes that were not unacceptably worse than in person. So comparable to in-person CBT in terms of things that are important outcomes in pain, like pain intensity, physical and emotional functioning. And then also we looked at things like treatment dropout to see if patients really liked or tolerated the intervention. So a little bit about this treatment, because it kind of interacts with the treatment that we developed and testing now. So I'll tell you a little bit about it. So this is self-directed CBT. Patients do it at home. It's a 10-week treatment. They get a pain management skills handbook where they learn the skills. So they learn one skill each week. We also send them a pedometer, and we ask them to engage in a walking program because physical activity is helpful for people in managing chronic pain. And each week they have 3 goals in the program. You're going to learn this pain management skill, and we'd like you to practice it every day. We're going to ask you to increase your steps by 10% over what you did in the prior week. And we want you to pick some kind of productive, social, or pleasant activity goal that you're going to work on that week. Each day of the week, we would send them an IVR call. We now do it by SMS survey link, where they answer a really brief collection of questions about how they're doing, their pain, their sleep, their pain interference, their steps, and did they practice the skills. It takes about a minute or 2 for them to complete the survey. They do that each day. And then at the end of a week, a coach will look over the data that they provided to us and create a personalized feedback message for them. So the coach leaves this message on their phone, and the patient can listen to it at the end of each week. So the coach and the patient don't really ever meet or talk in real time. They kind of have this asynchronous communication. So that's the treatment that we were examining relative to standard in-person care. Okay, so the outcomes of that trial were published in JAMA Internal Medicine and some other journals for other aspects of the trial. And what we found was that COPES was no less effective. It was not inferior to in-person CBT for reducing pain intensity. So patients in both conditions had significant, clinically and statistically significant improvements in pain intensity, disability, and sleep. And they also significantly increased their physical activity. So about 1,700 to 2,000 steps a day. And that is about an extra mile of walking a day. And so this isn't a sample of patients who were sedentary, on average, obese, older participants who had long-standing chronic pain. So we were quite pleased with this, and we've gone on to test this intervention in some other populations and adapt it. It continues to show benefit, and patients continue to express satisfaction and like the treatment. So that's kind of the background of how I started kind of my research career. So how does this move into this new treatment that I'm working on testing that's really for patients who have chronic pain, but also opioid use disorder and who are receiving medication for opioid use disorder, or MOUD. And this is the IMPACT trial. So I was approached by Dr. Kathy Carroll, who's very senior Yale investigator, and she has a long history of examining technology-based interventions based in CBT also that were for addictions. And she was interested in us applying for a grant to integrate our two treatments, so hers for CBT and mine for chronic pain, for patients who are receiving MOUD and have chronic pain. And so, why is that? So chronic pain is very common among individuals who are enrolled in MOUD, with estimates in the literature ranging from 40 to 80%, depending on how it's measured. That individuals with chronic pain have poorer MOUD treatment outcomes. They have higher craving, higher rates of drug use, and higher rates of relapse. Individuals receiving MOUD often have difficulty accessing evidence-based pain care. And these patients are often very complex and have poor access to other pain care. So a technology-based self-directed treatment would be really well suited for this type of population. That was our thought going in. So our trial was funded, and it's been ongoing for a couple years now. So this is kind of a two-part trial, R61 and R33, but you can easily think of it as phase 1 and phase 2. So phase 1, and this is the part that's completed, is really to develop and test a web-based program that we're calling IMPACT to address chronic pain in individuals who are enrolled in MOUD treatment. So integrating these two kind of programs that we had already tested separately. So we wanted to do that, build a new system based on feedback from experts and patients and clinicians too, actually, and conduct some initial testing about acceptability, and then moving into what is called the R33 or phase 2, and that's the actual clinical trial. And that's where we are right now. This is an ongoing clinical trial. So conducting a randomized clinical trial, evaluating the efficacy of this IMPACT treatment relative to standard care in 160 individuals who have chronic pain and OUD and who are being treated with either buprenorphine or methadone. And our primary outcome is retention in MOUD. So we know that retention typically is around only 50%, but retention is crucial, especially in early in treatment, for patients to get full protective benefit of the treatment. We're also looking at pain interference and some other secondary outcomes like opioid or other drug use during treatment, service utilization, sleep quality, catastrophizing, and treatment satisfaction. So I want to walk you through a little bit about what we've done in AIM-1, developing the treatment. I'll let you see a little bit about what the treatment includes and kind of help really conceptualize what it is. So I told you a little bit about COPES already and that bit of it, but so Dr. Carroll and her group were one of the earliest to develop and evaluate web-based versions of CBT for addictions, and she has tested it in a number of different substance use disorders. including 2 trials indicating its effectiveness and durability for individuals who are on methadone maintenance or individuals in office-based buprenorphine. So a little bit about these. So we have these 2 very different treatments. We had to kind of think about how would we put these 2 together. So Dr. Carroll's CBT for CBT are web-based, video-based, self-directed treatments. So luckily, there are a lot of similarities between the treatments that really kind of helped us integrate them. They're both based in CBT. Both of them are set up to learn 1 skill per week, with weekly practice and goal setting of those skills. And both of them in the systems that kind of track the use of the treatment by the participant. However, there were some differences. As I said, CBT for CBT is web-based. It's designed to be very interactive. It has characters that patients follow over the course of treatment, watching them learn and use the skills. It has interactive content. HOPES, which is based in IVR, doesn't have that, but it had a couple different aspects that were different. First, it had the walking component, so asking people to increase their physical activity. It had this daily assessment and then actual personalized feedback. So that's what we set about trying to integrate. So we had several steps that we went through to do that. So consulting with an expert panel, doing some qualitative interviews with patients and clinicians, and doing some focus group feedback. So we met with the expert panel, and their suggestions for us were really to do a few things. To really think about the connections between OUD and chronic pain, and think about how those 2 conditions influence each other. So how, for example, how pain or pain flares can aggravate craving that then could put people at risk for not remaining on their MOUD treatment. And to think about the coping skills that are present in both of these treatments, which are often the same skills. So how those skills could be used for each of the aspects of the 2 conditions. So for example, CBT typically includes relaxation training. So use of progressive muscle relaxation or imagery, deep breathing, those kinds of things to help people relax. In chronic pain, that is to reduce stress, reduce muscle tension that can aggravate pain. It's often used in OUD treatment to reduce cravings and stress. And so to really emphasize to people who use the treatment, how you could use 1 skill that could be helpful for both of the conditions at the same time. So really building self-efficacy and reinforcing coping skill use for patients who may not be aware of all these connections. And then really build supportive connection through coach feedback. Okay, so I think I reached the end of the first set. So I'm going to retrieve the second half. I guess this is a good place to think about stopping and asking if there are any questions. Okay, I'm not seeing any questions yet.
Actually, I do have a question. Sorry. I saw on the slide that it was indicated that when someone is experiencing chronic pain, that then being on MAT can be less successful. And I was just wondering if you could, if I understood that correctly, if you could speak to it a little bit more.
Yes. So there is some evidence that when people have chronic pain, that I don't think it's necessary. So they may do less well in MOUD treatment. So they may be less likely to be retained in treatment, right? And the thought is that what it is because they are having to manage pain also. So they may be more likely, maybe, say, to return to the use of opioids, to have cravings or other difficulties that are associated with both conditions, right? Could be aggravated. That could become a barrier to remaining in MOUD treatment. Does that make sense? So you're really kind of like overloading a person's capacity in some way.
It does, thank you.
Okay, so let's see here. Going to close this. Let's make sure we get the right slides here. Okay. I appreciate everyone's patience while I negotiate this. Okay, I think, yeah, might have lost a slide, but I think we're going to be okay. Okay. All right. Can y'all see that?
Yes.
Okay, thank you. Sorry, I can't see you. I have your faces hidden, so I have enough room to see what I'm presenting on. Sorry. Okay, so I think we lost a little slide, but it was just a setup for kind of the next step where we actually conducted semi-structured qualitative interviews with both patients who have OUD and chronic pain and who are receiving MOUD from a treatment clinic, and from clinicians and counselors who worked in those clinics. These were individual interviews that we conducted via Zoom. This was during the height of the pandemic. And we really were interested on the patient side. We wanted to get more information about their experience of chronic pain and OUD and receiving MOUD treatment, to see if, one, we would find enough patients who said they had chronic pain, what they thought of managing these two conditions and what they needed in terms of crafting our intervention, and then also to speak with clinicians to learn a little bit more about things that they may notice about chronic pain in this population. So just breaking it down into the themes, the major themes that came out of these interviews were, one, that there were really kind of two pathways to chronic pain and OUD. So there were people that we interviewed who said, I kind of started with OUD, and over time, either through aging or oftentimes related to traumas or accidents that had occurred during the period of time when the person was using opioids, they developed chronic pain, and so had both of those conditions together. And then there was another population that started with chronic pain, started oftentimes with a prescription opioid by a physician or other prescriber, that then transitioned into OUD. So you have really two different types of patients. And this was really informative for us because, as I said, in this intervention, it's really built around characters and following them through their experience of treatment. And so as we were building, and as you'll see when I show you a little bit more about the treatment, we really built it around two characters, one showing each one of these patterns. So many of them said in terms of so MOUD they felt was helpful. It was very helpful, and everyone that we spoke to described MOUD treatment as quite helpful to them in treating their OUD. Many of them said that they did receive some pain relief from their MOUD, but it often was not enough to fully manage the pain. So they were left with some aspect of pain to manage on their own. The patients often were not aware of pain treatment options, so they weren't aware of other ways to manage pain beyond medication, or they weren't able to access it, either through lack of adequate insurance or just difficulty getting to these treatments, finding a treater, or knowing about some of the non-drug ways to treat pain. The clinicians that we spoke to, we were curious about whether clinicians would say, yes, I think my patients, actually, a fair number of them experience chronic pain. And that was the feedback that we got. They did say, yes, I would say, a fair number of my patients they experience chronic pain. So I think this would be valuable among this population. They don't have access often to pain treatment. And some of the clinicians at least said, my background, my training is in addictions. It's not in chronic pain. So I don't have the training to be thinking about how to address that with my patients. So overall, we came away from some of these interviews thinking, yes, there was a need that we could fill here. So in terms of building the treatment, we relied on some what Kathy Carroll and her group had used as a framework to build the treatments. So kind of as a patient, they open the treatment, this web-based treatment. They kind of have a little check-in, a review of their practice for the prior week, an introduction. Here's what we're going to teach this week, a video of the character that they've been following in a challenging situation where they're dealing with pain and or cravings, teaching of the skill and a demonstration of the skill with another vignette, and then a practice exercise and a quiz for understanding. We also decided we wanted to keep that walking, the daily step goal, the walking part of it. Patients in the trials for chronic pain very much like the walking. It's very kind of concrete. You have a goal for the day, how many steps you're going to walk, and it's something that is very easy to see if you're meeting that goal or not. We wanted to keep the daily survey and the weekly coach feedback. So we created what we're calling Impact. It's a 9-week web-based treatment that is supplemented by these personalized weekly feedback messages from coaches. So these are the skills or the topics, and each one has a skill that goes with it that we teach in the treatment. There's walking, or the importance of physical activity for managing pain and improving sleep. Engaging in meaningful activities, relaxation through deep breathing, or muscle relaxation, but also stretching for pain and distraction as a skill for addressing both pain and craving. Improving decision-making, pacing activities as not to aggravate pain, tips for improving sleep, communication, especially with providers and family members, and then planning ahead for next steps as treatment ends. So just a few kind of screenshots. So this is kind of a display. This is how patients who are entered into the trial, so they receive a survey every day, and this is kind of how it looks on their phone, right? So they get a link, they click on the link, and they get asked these questions. So what tools did you use today? These are the skills. How many steps? Did you take your medication as prescribed? How was your pain and your cravings? And then once a week, when they log into the website to learn the new skill for the week, they have a coach feedback that they just click, and they get a personalized message from a coach that kind of walks them through reinforcement for what they're doing, and also kind of talking about the way these different skills and factors are related to each other. So when they log in initially, so on the right side, this is the landing page. So you'll see there's an icon, and these icons are each skill that they learn. So before they've learned the skill, it's kind of grayed out. But after they complete the module, it turns this darker blue color that you see here. So they can kind of see their progress. The little stars are as they indicate through the program that they're using. The star will light up, and it'll also have a number here. Then at the top, that top left part, that's where they click for their coach feedback. The graph shows them their walking and how they're doing with that over the weeks. On this left side, this just shows our narrator. So this is our narrator, and she appears in the beginning every week to kind of walk the patient through what the skill will be for that week. And we have this little reminder here of kind of the 3 goals to keep that in mind so people see that in a very simple way. Each week, we're going to ask you to walk, learn your tool and practice it, and stay in your OUT treatment and take your medication. So these are the characters. So we have 2 characters, Jackie here on the left and Leo on the right. So this was really very interesting. For me, at least, something I had never done. Dr. Carroll's team had certainly done this in the past. This involved casting actors and writing scripts that really show, hopefully, the lived experience of people as they use these tools. So Jackie, she has lower back pain from a car accident in which she lost her husband. After the accident, she was prescribed OxyContin, which temporarily helped, but she started to need more pills and use more pills. And after discussion about the risk of overdose and unmanaged pain, she was referred to a buprenorphine prescriber. And then Leo began using substances as a teenager and continued in his adult life. He was fired from his job as an EMT for testing positive for heroin. He's been taking methadone for a year, and although he's not used in the past 6 months, he's angry that his life is not where it wants to be, where he wants it to be. So as you can see, we've got some pictures of the characters who we follow through. At the end of each module, we also have these really short testimonials And so this is a way, it's just a 1 or 2 minute video to kind of click and hear how other patients might use the skills or their experiences. So we've tried to make it very interactive as skills are introduced. So like you can see over here on the right side, when we talk about stretching, they can watch a video of the characters doing the different stretches. We have animated examples of different concepts. You can see that here on the lower left side. And then also, as a teaching tool, we've tried to make it interactive. So in the communication where we're talking about the benefits of assertive versus passive or aggressive communication, they'll get to hear, they'll get to see video of the characters and their responses, and then rate whether they think that is an assertive, passive, or aggressive response, and then they'll get feedback on whether that was the correct answer or not. So they have a lot of different skill building. So typically at the end of each of the modules, and each module lasts about 35 minutes, I think, they get walked through how to make a goal for that week. So they answer some questions, and then the system will show them at the end what their selected goal is. And we do that so that they will make goals that are specific and measurable and achievable. And then at the end, we took the system and we showed it to 5 providers and 5 patients from a community treatment organization, and asked them in some individual interviews about the understandability, the potential helpfulness, and their interest in this type of treatment. And we got pretty good feedback, around 4.2 or 4.3 out of 5. Which was above our benchmark for going forward to the next phase. So this is the phase that we're in now, and that is conducting a randomized clinical trial to evaluate impact. So just to remind you, in this part of this phase 2, we're conducting this randomized trial evaluating impact versus treatment as usual or standard care among 160 participants who are enrolled in MOUD, methadone or buprenorphine, and who have chronic pain. So we're evaluating the efficacy. Our primary endpoint is 3 months, so that's about the end of treatment. So the treatment is 9 weeks. We give them a cushion, give them a few extra weeks to complete treatment. As I said before, the primary outcome is retention in MOUD, which is defined as continuous and verified enrollment in MOUD treatment at 3 months. And then our primary pain outcome is the pain interference short form. Then we also do assessments up to 6 months to evaluate the durability of the effects of treatment on retention in MOUD and pain interference. And as I mentioned, we have a number of different secondary outcomes, especially things like use of other opioids or other drugs, opioid-related consequences, adherence to buprenorphine or methadone, depending on which they're taking, sleep quality, catastrophizing self-efficacy, and treatment satisfaction. So this is being conducted in multiple outpatient treatment centers in order to attain our sample of 160. Our participants meet DSM criteria for OUD. They're enrolled in methadone or buprenorphine treatment. They have pain that is 4 or greater on the 0 to 10 point pain rating scale. So 0 being no pain and 10 being the worst pain imaginable, on at least half of the days in the prior month. So this would be classified as, bothersome or high impact chronic pain. So we wanted folks who had a fair amount of pain, enough pain that we presume that it would interfere with their daily activities, and that would motivate them to want to be in treatment. They have to be able to walk a block, because we do have the walking portion of the treatment. Read and understand English at a 6th grade level, and no severe conditions that would impair their ability to participate. Someone who has active suicidal intent, poorly treated psychosis or bipolar disorder, need for palliative care, those kinds of things. Recruitment is done from the treatment clinic, so that's referral from counselors or patients who are responding to flyers that are hung in the clinic area. And then patients are randomized 1-to-1 in either of the treatment conditions. So this is just a little visual. So patients are recruited into the study through the methods that I just mentioned. They come to see the study RA. So we have, this study is currently up and going in 2 different clinics. So there is one RA who's in the clinic full-time. Patients who are referred will be screened to see if they're eligible and interested. If they screen eligible and they're interested, then they can go on to get a baseline assessment of a number of different factors related to pain, addiction, and MAD treatment. They're then randomized to standard care or impact. So the active phase is 12 weeks. So in both treatment arms, patients come in for kind of a very quick weekly assessment with the RA. Takes about 20 minutes max, where the patient they'll be asked to do a timeline follow back of any opioid or other drug use, adherence to their MOUD treatment. If they're in the impact condition, we ask them if they've done their treatment module for that week. They can also do the treatment module with the RA. And then, or they can do it at home. We also supply tablets or other devices for patients who don't have access to those. And so they would be doing one module a week. Takes, as I said, about 30 to 35 minutes. And then at the end of the 12 weeks, there is an assessment period that's post-treatment, and then they get further 1, 3, and 6 month follow-up treatments. So this is the last slide, I think. So this is our progress so far. So we are currently at 2 different clinics. Liberation, that was our first clinic. We started recruiting there in July of 2022. And then just this year, we started recruiting at Connecticut Counseling. So the numbers are a little bit different, mostly due to time. So we've had interest in the treatment from both clinicians and patients who are referred. And then some number of those agree to be screened, come in and are screened and then randomized. So we have actually 40 patients who have been randomized to the trial. Over that time, we've had 3 who've completed all the way, who've reached all the way to that 6-month post-treatment time point. Many of them have not quite gotten that far yet. That's why that number is so low. And since we just started at Connecticut Counseling, we haven't had anyone get to that point yet. So that's where we're at right now. We are always looking to add new clinics and being able to offer this treatment to patients. So we are anticipating that we will add one more clinic to this trial. That is what we had planned for, was 3 from the beginning. And thus far, we're very pleased with engagement from patients and interest and uptake of the treatment. I'm going to stop there so that I can see folks again. Right, so I'd love to have any questions. If there was anything that you're interested in hearing more about, or anything that I didn't quite explain as well as you would have liked. Oh, I see someone with their hand up. Eleanor? Oh, I think you're on mute.
Okay, can you hear me now?
Yes.
So how is this done on people's phones or laptops, or how do they do this?
So they can do either.
Okay.
So typically they prefer to get the link for the survey that they do every day on their phone. And we prefer that too, because, well, I don't know, maybe this is a confession. If you're me, you've always got your phone right at hand, if not in your hand, right? And then to do the actual treatment, so some people will do it on the phone. Some people will use the tablet, and then they can use the laptop that we have in the setting if they don't have something in their home to use. So we try to give people a number of different options because not everyone has access to the same things.
Okay, thank you.
Eleanor again.
Is there any plan to do it with our program?
Well, we're interested. And I'd love to hear, people who've listened, if you think that there's a need in your population. I see some hands, I see some head shaking. We'd love to do it. I think, obviously I'm biased, but I think it's a nice thing to be able to offer to patients for those who are randomized to the treatment arm, something that they can do easily, to its low burden. Maybe I should just say a little bit more about how that works in the clinics where we're up and running, so you kind of get a little sense of that. And that will help people think about it maybe with a little bit more detail in mind. So as I said, we have an RA who, in the places where we're up and running, kind of has a place where they sit. So they're available there anytime a patient is able to come and see them. We find that really helps. It really helps also that the counselors and clinicians and leadership get to know the RA. We find through personal relationships that really helps recruitment. And typically what we do is we figure out the easiest way within that clinic for clinicians or counselors to refer a patient, right? Usually the counselors especially are very close to the patients in terms of what's going on with them. And so typically those folks will refer people who are interested. We handle the screening. So I typically will say to counselors and clinicians, if they say, well, I don't know, would this person be eligible? And I say, okay, so let us sort that out. We will make sure they meet the eligibility criteria. But if the person has pain and they're interested in learning more about it, typically we'll make a flyer or something that counselor could give to a potential participant so they could see it. Then, we'll talk with them and do the screening, and then patients make an appointment for a screening. Typically, after they come in for their dose, so that it's convenient for them. So participants are compensated for their time in terms of after the baseline. They come in for this weekly check-in where we get important information about their continued adherence and use of their MOUD. So we do compensate them for those weekly appointments. And then the post-treatment and the follow-up appointments, we compensate them for those also. We try to be as flexible as possible. So when patients come in, we set them up to complete the measures. But sometimes patients will also, we will contact them by phone or send them a survey link so they can get those done if that's more convenient for them. So would love to hear any comments people have about the potential, about your site, if you think it would work at your site, you would be interested in learning more about that. We would, love to have Root Center as a site. My sense is that, well, I don't know, let me ask, in terms of patients, do most of your patients receive methadone or buprenorphine, or do you have a mix?
I think one of the counselors can speak more directly to that, but we definitely see offer up methadone more than bupe. Bupe is offered, correct me if I'm wrong, you guys, but only in Middletown currently. Is that accurate? Okay.
I'm from the New Britain clinic, and yeah, most of our patients are on methadone.
Okay. And that's true at our other two sites also? And I guess I should say too, like we accept patients who have been in treatment, who have been taking MOUD and are on a stable dose. So for those who are at the beginning of their treatment, that's usually after 2 to 3 weeks, and when their clinician says that their dose hasn't changed for 2 weeks. I can only see some of you, so if anyone has a question, you can just jump right in. I happen to be able to see Eleanor, so I saw her when she raised her hand, but if someone else would like to ask a question, just go ahead and jump in.
Hi, this is Shannon. I was wondering for folks that live in more rural areas, the walking piece may be a barrier. What kind of solutions have you guys had for folks to overcome that barrier?
Yeah, so we have people who use the walking in a lot of different ways. So some people will walk, like I'm going to go take a walk for 15 or 20 minutes. Some people just simply try to increase their activity around their home, right? Especially if they've been quite sedentary. We do have people who prefer to go someplace to walk. We have some folks who go to, say, the mall or a big box store and walk around. So I think the idea is to think about it more as general activity rather than, a bout of exercise. And for those people who were not very active in the beginning, so maybe there's a person who lives in a rural area and they haven't been being very active physically. The way the program is set up is that each person's goal is really pegged to where they start, right? So after the first week, they say, we look to see what their steps were. And then we give them a goal to increase their steps 10% relative to themselves. So each person is kind of, it is personalized in that way. And that people who kind of start out very low kind of go up very slowly. But this is an issue for some people, or also people who live in areas that might not be safe. They may not feel safe walking in their area. Typically, we'll walk in their home and try to increase their activity in that way, which they do get increases, but it is a challenge. It is definitely a challenge. And it is a challenge for some patients more than others. We do, as I said, if a patient lives in an area that's not safe or not walkable, this is a challenge. I mentioned that we have some participants in the past who've told us they've gone to stores to walk around. And in some of our other trials where it's face-to-face, and we've had a patient maybe raise a concern about being able to do the walking and offered that as a suggestion, they have said, which is absolutely valid, I'm a member of a minoritized population and I can't just go to a store and walk around and not buy anything because I'm afraid someone is going to think I'm going to steal something or hassle me. That would not be comfortable for me. So we don't, patients enjoy the walking, but I will admit it's hard. There are barriers for some patients.
Thank you.
Any other questions or anything I can answer? I want to thank you all for your attention and your patience with our technical difficulties. We did, with the help of my crack IT team here in the house, breaking down the slides and sending them back to me.
Well, thank you very much, Dr. Heapy.
Thank you for having me. I appreciate it.
Absolutely.